Hello everyone, in this video I will discuss about the treatment of thyroid diseases. Now for the treatment first you need to diagnose, okay, so proper diagnosis required. Now to diagnose the disease of thyroid gland we perform thyroid function test, okay, where we measure the free T3, T4 and TSH levels. So the T3 and T4 estimation are the most commonly performed thyroid function test, okay, and this T3 and T4 they don't have any food relation. You can take food also before going to the test, but the TSH, okay, so here you should go empty stomach. For TSH, empty stomach is required. Okay, so when you measure the T3, T4 and TSH level, you could fall in different scenarios. Okay, so let's discuss all of them. So if your TSH is low, okay, and free T4 is high and free T3 is also high, and it's a classic case of hyperthyroidism. Okay, so because your T3 and T4 are high, that's why your TSH is low. Okay, now next, if your TSH is low, free T4 is low and free T3 is normal, then it's a case of subclinical hyperthyroidism. Okay, then it's a subclinical case. Now when your T4 is normal and your T3 is high and your TSH is low, now that is your T3 only, okay, T3 only toxicosis. Okay, so T4 is normal, TSH is low, only T3 is increased. So that condition is a T3 toxicosis. Now when your TSH is low, free T4 is high and your free T3 is normal, in that case it would be thyroiditis, or your T4 ingestion means the patient might be on drugs, hyperthyroidism in the elderly patients or with comorbid illness. Okay, so free T4 high means thyroiditis or T4 intake or elder patient with comorbid illness. Now next is low TSH, low T3 and low T4. So everything is low here, then it's a euthyroid state. Okay, euthyroid syndrome or central hypothyroidism. Now when your TSH is high, T3 and T4 are normal. What is that condition? That condition is subclinical hypothyroidism. Okay, or if that is not the condition, then it could be the recovery from euthyroid 6 syndrome. Okay, now next is this flow chart. Okay, so let's say we are suspecting a case of hyperthyroidism, and now we have performed our serum TSH levels. Now let's discuss this. If the value comes out to be less than zero point 0.3, then what will happen? Then we go for T3 and free T4 index. Okay, and if that comes high, then it would be your hyperthyroid state. Okay, and if it is normal, then it's a case of subclinical hyperthyroidism. Okay, and when it's a case of subclinical hyperthyroid state, then it could be your hyperthyroid symptoms, okay, or without symptoms. Either the symptoms are present or absent. Okay, so if the symptoms they are present, then we check for whether it is a diffuse goiter, okay, or thyroid nodules, and here we check the TPO antibodies, thyroperoxidase antibodies. Okay, so if it's diffuse, then it is your Graves disease. If only nodules are there, then we go for radioactive iodine uptake test. Okay, and if there is high uptake, then again it's in Graves disease or your toxic multinodular goiter, and if the uptake is less, then it is subacute thyroiditis, or you can say factitious thyrotoxicosis, stroma overi, or thyroid metastasis. Okay, now if the level is more than 3, then what will happen? Then again we go for T3 and free T4 indexing. Now if it comes out to be normal, then there is no need to go for further investigations. Okay, and if it's high, then it could be the pituitary adenoma, okay, or pituitary resistance to T3 suppression. Okay, so this flowchart is important. Now next is, if we are suspecting a case of hypothyroid patient, then again serum TSH estimation is done, and if it is between 0.3 to 5, then we go for free T4 indexing, and if it comes out low, then we assume it's a case of pituitary insufficiency or drug-induced hypothyroidism. And if it is normal, then the only thing which could be possible is high reverse T3 levels. Okay, high reverse T3 levels, and if that is raised, then it's a sick euthyroid syndrome. Now, if the value is more than more than 5, then the free T4 indexing is done. If it is low, then it's a simple case of thyroid peroxidase antibody testing. Okay, then we go for thyroid peroxidase antibody testing. If it comes out to be positive, then it's a case of Hashimoto's thyroiditis, and if it is absent, and then the ESR estimation is done. Okay, so if your antibodies are absent, TPO antibodies are absent, and ESR is raised, then it's the case of subacute thyroiditis. Okay, and if free T4 is normal, then it could be your low T4 binding protein peripheral resistance to T3 or T4. Now, the investigation for thyroid diseases. Now you can perform the USG. Now, under USG, high frequency ultrasound is useful. Okay, and investigations, especially in case of solitary nodules or your multinodular goiters. Okay, or USG guided FNEC can also be performed. Now, the thyroid scan with isotopes. Now, this isotope scanning is done with I123, okay, or your I131. Now, the iodine scintigraphy is used to evaluate the functional status of gland. Now, that is important. It's a functional test, okay, whether the gland is functional or not. The primary use of thyroid scan is to determine whether the palpated nodule are functional or non-functional, okay, and it detects the difference between toxic adenoma and toxic multinodular goiter. Okay, we can find out the three different patterns. First is hot nodule. Hot nodule means high activity, means some particular portion of gland is doing extra work. Okay, or it is overactive. Now, this nodule with relatively increased uptake of isotope than the surrounding tissue is known as hot nodule. Now, it means the gland doesn't take up the isotope. Okay, only that particular nodule is taking all the isotopes. Okay, and the risk of malignancy is very less, 1 to 3% in case of hot nodule. Okay, now for warm nodule, again the condition is active and the entire gland take up the isotope. That is the difference. Here the entire gland take up the isotope, and the example is here Graves disease. Now, third condition is cold nodule. Now, cold nodule means the nodule doesn't take up isotope as compared to the surrounding tissue. Here, one particular nodule you will find to be least active. Okay. Now, because it is not doing any work. Okay, so it has more likely to be malignant. Okay, that way you can remember it. And the chances of malignancy are 10 to 20%. That is important. Now, here for your scintigraphy, we use I123. Okay, for scintigraphy, we use I123, and for treatment purpose, we use I131. For ablation, we use iodine 131 isotope. Okay, so that is the difference which you should remember for your exam. Now, this cold nodule, let's revise it again. Cold nodule means decrease uptake of radioactive iodine. Okay, Graves disease, increase uptake of radioactive iodine on all thyroid tissues. Toxic multinodular goiter means increase uptake and decrease uptake in central tissues. Okay, the hot nodule means increase uptake. Autonomous nodule means increase uptake in one nodule with suppression of remainder of the gland. Now, in thyroiditis, where the gland is damaged, there is decrease radioactive iodine uptake. That is important. Okay, here you can see the cold nodule. Okay, here entire gland is active, and here only one particular nodule is active. Okay, so that's important for your exam. They can ask these pictures also. Now in Graves' disease, you have your entire gland taking up the radioiodine, okay, radioactive iodine, and in your multinodular goiter, different nodules in the gland, they take more and more radioactive iodine, and in autonomous nodule, one portion take up iodine and it suppresses the nearby tissues, and in the thyroiditis, very less uptake, okay, because the gland is damaged. So all these are important. Now the isotope 132 has T half of 2.3 hours, okay, means it has very short T half. 123 has 13 hours of T half, and 131 has 8 days, okay, longer. So that's why we use it for ablation, okay, we use it for ablation, and it emits beta rays, 90% beta rays and 10% your gamma rays, okay. Gamma rays are responsible for the side effects. Beta rays helps in ablation, okay, so that is important. And 123 is used for diagnostic purpose like in scintigraphy, and 131 is for your therapeutic purposes, okay. And your normal iodine, that is 127, and I125 iodine 125 isotope is used in your brachytherapy and radio immunoassay, okay. So that is again important for your entrance exams. Now whenever you go for radioiodine, okay, so what you need to do is prior to radio iodine assay, 1 month antithyroid drugs are indicated, okay, to achieve euthyroid state. That is important, otherwise it can precipitate thyroid storm, okay. So we first prescribe antithyroid drugs, okay, to make the gland euthyroid. Otherwise, what will happen? It can trigger the thyroid storm in the patient. So that is important, and it is contraindicated in pregnancy and as well as in children's. Okay, and the 10% are chances that the patient might go into permanent hypothyroidism like state. Okay, so these are important points for your radioiodine. Now next is thyroidectomy. Now thyroidectomy simply means removal of gland. Okay, so the surgical approach to remove a diseased thyroid gland is mostly preferred according to severity and need. Okay, and the father of thyroidectomy is your Theodore Kocher, and the position is important, and we call it roses in tray position. Okay, I will show the picture. It is how this position is achieved by elevating 50 degree. Okay, you elevate the head portion 15-degree elevated, or you can say the tilted table, and that helps to reduce the venous congestion. Now the neck is hyperextended with sandbag under the patient's shoulder. That is the position. Okay, 15-degree up and sandbag behind the shoulder, and neck is extended. Okay, so that is how you achieve this roses in tray position for your thyroid surgeries. Now you have different thyroidectomy techniques. Okay, let's discuss all of them. First is your total thyroidectomy. Here you remove all the visible thyroid tissue. Okay, in thyroid you have lobes and isthmus. Okay, so you have lobes and isthmus. Okay, so that is your isthmus. Okay, and these are your lobes. So when you remove everything, that is a total thyroidectomy. Now what is hemithyroidectomy? It is removal of one lobe of thyroid with isthmus. Okay, so that is your one lobe, isthmus, and other lobe. So what is hemithyroidectomy? Removal of one lobe. So this is removed with isthmus plus isthmus. Okay, so that is your hemithyroidectomy. Now it is done in thyroid cyst and in benign enlargement of the glands. Okay. Now, next is subtotal thyroidectomy. Now in subtotal thyroidectomy, what we do is we leave 3 to 4 gram of thyroid tissue in each lobe, and rest of the gland is removed. Okay, so if this is your thyroid gland, okay, we are leaving 3 to 4 gram tissue, okay, and we remove the rest of the gland. So that is your subtotal thyroidectomy. Next is near total thyroidectomy. Now, near total, leaving 1 to 2 gram of thyroid tissue and rest of the gland is removed. So, in near total, we just keep 1 to 2 gram of thyroid tissue in one of the lobes. Okay. Then you have Hartley-Dunhill procedure. What is that? Only 4 to 6 gram of thyroid tissue is preserved in one lobe. Okay, per side, and rest of the gland is removed. So these are very important for your exam. But the important thing is that the subtotal and near total thyroidectomy. Okay, so these two. Now, if they leave behind thyroid tissue, what will happen? It would be enough for the body's thyroid hormone requirement. Okay, that was the assumptions. But on further clinical studies, they found that they could not prevent parathyroids. Okay, while doing that. Okay, why they were leaving certain tissue? They think that by leaving certain tissue that will suffice the requirement of the patient's thyroid hormones, and it will prevent parathyroids as well. Okay, plus it will prevent the recurrent laryngeal nerve injury. So because of that, they were leaving some tissues. Okay, but later it was confirmed from studies that this small amount of left tissue is not enough. Okay, and even the recurrent laryngeal nerve injury rate is still remains same. Okay, so these two are avoided nowadays. So mostly you will see either hemithyroidectomy or total thyroidectomy. Okay, so these are the pictures which we have discussed. This is a total thyroidectomy where we remove total gland, both the lobes and isthmus. Then you have hemithyroidectomy where we remove one lobe and isthmus. Okay, then subtotal thyroidectomy where we preserve 1 to 2 gram of tissue on both the lobes. Then you have Hartley-Dunhill procedure where we leave 4 to 6 gram of tissue, okay, on both sides. And then near total thyroidectomy, leaving less than 1 gram of tissue adjacent to recurrent laryngeal nerve. Okay, so that is important, near ligament of Berry. So these pictures are important for your exam. Now the complications of thyroidectomy. So the first is your hemorrhage. Okay, so hemorrhage is one complication. Now the important is that now why this hemorrhage occurs. Now it is due to the slippage of ligature. It's due to slipping of ligature on the superior thyroid artery and bleeding from the muscular artery. Okay. Now the hematoma, it may occur immediately or it might take some time. Okay. An immediate bleed occur after shortly before extubation when the patient lightens from anesthesia and may begin to cough, causing a vessel to open. Okay, so that is again one condition, immediate bleeding during the extubation. Then the delayed hemorrhage develops slowly and therefore may not be recognized at first. Okay. Now next is respiratory obstruction. Now it is because of tension hematoma or laryngeal edema. Okay, and most common cause of respiratory obstruction is your laryngeal edema. That is important for your entrance exams. Then the bilateral recurrent nerve paralysis uh, is also one of the leading cause of respiratory obstruction. Okay. Now next is recurrent laryngeal nerve paralysis. Now this could be unilateral or bilateral, transient or permanent, and based on that it can cause respiratory obstruction, dyspnea or stridor. Now injury could happen to the nearby vessels and nerves as well. So the external branch of superior laryngeal nerve, this nerve is also at high risk, and cervical sympathetic trunk. Okay, so this is also, and if this damage, it can lead to Horner syndrome. Next is parathyroid insufficiency. Now due to removal of parathyroid glands or infarction due to vascular injury. Now that is important. Infarction due to vascular injury, it is because of injury to inferior thyroid artery. Okay, then because of that there is ischemia or infarction and the parathyroids may be damaged. Now this vascular injury is more important. Okay, Now the cases usually present 2 to 5 days after the operation with symptoms of hypocalcemia, okay, like circumoral and fingertip numbness, or tingling sensations, or tetany, or carpopedal spasm, even laryngeal stridor. Okay, so these are the presenting symptoms of such patients. Now the treatment with oral calcium and vitamin D supplement is required, and IV calcium gluconate may be required in severe cases. Okay, now next complication is thyroid insufficiency and thyroid crisis as well. Okay, so thyroid crisis, or you can say thyrotoxic patient, has been the inadequately prepared for thyroidectomy. Means if your patient is not prepared, then only it can end up in thyrotoxic state.